And on your slide it says negative and positive pressure. We don't even talk about negative pressure ventilators, so you can cross that off your slide. I was told by Respiratory that they don't do iron lungs anymore or anything remotely like that, so we're not going to talk about those. But what we are going to talk about are positive pressure ventilators. Now we already talked about the non-invasive positive pressure, the CPAP, the BiPAP, and now we're going to talk about the invasive positive pressure ventilators. This is where generated pressure pushes air into the lungs through an endotracheal tube or a trach. And there's three types of the way ventilators can be set up to deliver the breaths. There's time cycled, which is going to push air into the lungs until a preset time is reached. And we don't really use that much anymore. Why do you think that would be a problem? It's not like normal breathing, and what can happen? Overinflation, hyperinflation, even damage. You can even blow out the lung. Volume cycled ventilators, and these are the most common types, similar to what she was showing you here. And this is where a preset tidal volume, which is the volume of air that's going to be delivered with each breath, is programmed into the ventilator, and it will continue to push air into the lungs until that tidal volume is met. Now, if it's only volume cycled, then what kind of problem are you going to have? What if it puts too much air in and the lungs can't handle? It's going to keep pushing that air in until that preset tidal volume is happening, is delivered, and that can cause, again, overinflation or barotrauma, damage to the lungs. So most ventilators that you're going to see are going to be a combination of volume and pressure cycled. You're going to have a set tidal volume that's going to be delivered, a volume of air with each breath. But there's also going to be a pressure setting on that vent that's going to stop the ventilator from delivering that breath if a certain amount of resistance is met. And so the patient, the doctor is going to prescribe that based on the patient's lung compliance and their status as to how much pressure they can tolerate before we could possibly have damage to the lung. So the volume is going to be delivered, but if it meets resistance before that volume is delivered, it's going to stop delivering the vent and it's going to alarm. There's a lot of different types of vents, as she was saying. Controlled mandatory. That's for the patient that doesn't have any respiratory effort on their own, no respiratory drive. It's a set volume, a set rate, and it continues to give that patient, so the patient is 100% dependent on that ventilator. Controlled mandatory. If the patient is on assist control, which is very common, particularly patients that are long-term vent patients, they're able to take some spontaneous breaths, but not enough per minute and not enough tidal volume per minute to keep them, well ventilated and in a healthy state. So again, it's going to be a set rate and tidal volume, but the patient can take spontaneous breaths, and the ventilator will continue to give that set rate of breaths per minute, regardless of how many spontaneous breaths the patient takes on their own. So what do you think might be the problem with assist control ventilation? Anxiety, but what physiologically can happen if the patient, say the vent is set for 10 breaths per minute, and then the patient takes 2 additional breaths? What do you think can happen? Overinflation, hyperinflation, respiratory alkalosis, because they're getting too many breaths, too much tidal volume, more than what they can tolerate. And then you have intermittent mandatory ventilation or synchronized intermittent mandatory ventilation. And what that ventilator does, it has a set rate, number of breaths per minute, set tidal volume, guarantees that set rate even if the patient stops breathing. But with the intermittent and synchronized, if the patient takes a breath on their own, the ventilator will not give additional breaths per minute. They will just get what that set rate is. So it's only going to give those breaths to maintain, say, a 10 breath per minute rate. the patient takes 2 breaths on their own, then the ventilator is only going to give them 8 breaths. So there's no hyperventilation, there's no extra tidal volume that the patient is getting, and you're also able to see on that type of ventilator how many independent spontaneous breaths the patient is taking and how many are being delivered by the ventilator. So what would be the benefit of that? Exactly, that's going to help you decide how ready that patient is to be weaned. The more spontaneous breaths that show up, the better the chances of that patient being weaned. You may also see what they call inverse ratio ventilators. They're not very comfortable. Patients have to be sedated when they have these, because normally you have a 1:2 inspiration to expiration ratio in terms of the time. It's a shorter period of time to take in your breath than it is to exhale all the rest. So that's a 1:2 ratio. That's your normal normal ratio. Inverse ratio is the vent's going to be set at 1:1. So the expiratory phase and the inspiratory phase are going to be equal time, and that can be very uncomfortable for the patient. But what it does is that it allows more of the alveoli to be utilized during that inspiratory phase. High frequency, again, very uncomfortable. They can get small tidal volumes anywhere from 60 to 200 breaths per minute. So those are patients that have very poor lung compliance. Their lungs are very damaged. They can't tolerate high tidal volumes, so they're getting small amounts of air being forced in at a very high rate. Again, very uncomfortable. These patients are going to be sedated as well. These are the very, very sick patients. But remember, what we're going to focus on is what you are responsible for as the nurse. Not programming the vent, but assessing the patient that's on the vent and preventing complications. So you've got your pressure cycled vents, you've got pressure support vents, again where the vent will give a little bit extra air to the patient, and we can use that often for patients that are being weaned from the ventilator. CPAP can be delivered via the endotracheal tube. So it can be a non-invasive CPAP, or it can be CPAP with an endotracheal tube. Keeps that continuous pressure, keeping the alveoli expanded throughout the entire respiratory cycle. And then the airway pressure release, again, the APRV, those are the vents that are going to be used for those patients that you're going to be weaning. The terminology that might come up on an NCLEX question, and really that's all, these are really the only things that you kind of need to know about the ventilator settings. The tidal volume, which I think in the book they do a T with a small v, but you will also see it with a V with a small t. That's tidal volume. So what's the tidal volume? What's the definition? Total amount of air delivered in one breath by the ventilator, and it's usually 5 to 7 milliliters per kilogram, because obviously you can't put as much into the little baby as you can into the big old guy. The rate, usually 10 to 14 breaths per minute. FiO2, very common setting that's going to change a lot with the patient. So what is FiO2? What does it mean? Right. Fraction of inspired oxygen. It's the percentage of oxygen that the patient's going to be delivered. They can get anywhere from 21%, which is what? Room air, all the way up to 100%. And that's going to change based on the patient's condition, their ABGs, and all that. So that's one of the settings that you'll see being changed a lot. And of course, the lower the FiO2, the better their ventilatory status is, because they're able to oxygenate and they don't need the high levels of oxygen coming from the ventilator. And then positive end expiratory pressure, keeping those alveoli open at the end of expiration, because that's when they're at risk for collapsing. And that patient that has ARDS or other types of respiratory conditions that weaken the alveoli, that PEEP is going to help keep that, keep the lungs, the alveoli expanded. Pat talked about the low pressure alarm, the 2 different alarms that you're going to hear, depending on the vent. So if it's low pressure, That means that they're not getting ventilated, they're not getting air because there's a disconnection. That's the one where everybody comes running. Excuse me. High pressure alarm is when the ventilator's trying to push in that preset tidal volume and it meets resistance, that pressure setting. And that means that they've got a mucus plug, they're coughing, they're biting the tube, and you need to go and address that. With any kind of monitor that you're ever going to deal with, or I'm going to say the same thing when we talk about cardiac monitors. You treat the patient, ignore the monitor. Don't assume if the cardiac monitor says flatline that your patient is dead. Look at the patient and they may still be sitting there talking to you, and it could be a malfunction of the monitor. Same thing with the ventilator. If the alarm's going off, check the patient, because that's going to tell you what's going on with the patient, not what the readings might be on the ventilator settings. She told you all about VAPP, so I don't need to tell you about that. But just to tell you that Cooley Dickinson, which is a small community hospital up in Northampton, Mass., in 2007 had 5 cases of VAPP. They instituted that ventilator bundle, and by November 2nd of 2007 had gone 490 consecutive days without a case of VAPP. Now, as Pat told you, VAPP is something that Medicare won't reimburse the hospital for. And each case that they saved them $40,000 that came out of the hospital pocket when they had VAPP because insurance wasn't going to pay for it. So it's a huge medical expense. So now we're going to talk about some of the adverse effects of mechanical ventilation. Why do we have an increase in intracranial pressure when patients being mechanically ventilated? What's happening? Extra pressure in the chest. Pat said it several times. Higher intrathoracic pressure, what does it decrease? Venous return. So if we have decreased venous return, what's happening? Why does that cause increased intracranial pressure? Because the blood is backing up into the brain. And it's causing cerebral edema. So positive pressure, increased pressure inside the chest, backs up the blood into the brain. Altered mental status, same reason. You've got increased intracranial pressure, that's going to change their mental status. But what are some of the other things that can, when a patient's on a vent, that's going to create some problems? What other issues do they have? Anxiety. What else? Is it easy to sleep? I mean, could you have fallen asleep listening to that thing humming along while she was talking? So you got anxiety, you got sleep deprivation. All of those are going to cause confusion in that patient that's in the ICU. Decreased cardiac output. If you have increased intrathoracic pressure, and decreased venous return, what happens? Less blood coming back to the heart means less blood that can be pumped out of the heart. So you've got decreased cardiac output, you're going to have hypovolemia because you're not getting as much blood pumping out, or you're going to have fluid retention as fluid backs up into the periphery because it can't get back to the heart. What are we going to do to prevent DVTs? What kinds of things are we going to give the patient? Anticoagulants. What else? Pressure stockings. Getting them up and walking them. I've got this visual when she told me about that of walking patients around the ICU on a vent. That just blows my mind. We have to look for that barotrauma, problems when we over and hyperinflate that patient's lungs, and they already have lung damage, and they can blow a lung. Pneumothorax, collapse of the lung. We're going to talk about that a lot. GI bleeding, that peptic ulcer disease. It's stressful to be on a vent in the ICU. That patient is going to get a stress ulcer, and that's going to increase their risk of aspiration. So, all of that being said, what are you going to be assessing? You're walking into your patient's room, you know they're on a mechanical vent. What are you going to look for first? Ambu bag with a mask. I love that. What else are you going to check? Once you know there's an ambu bag with a mask, what do you think is your priority? How about making sure the endotracheal tube is where it's supposed to be? Yeah, check the placement of the tube. Are they breathing? Is the tube where it's supposed to be and not in their hand, or, you know, and you would assume that the event would be alarming, but still. So making sure that the settings on the vent are the way they should be. Make sure the patient's breathing. The tube is in the right place. The cuff is inflated. So you got to check that pilot balloon. And then what's your physical assessment going to be? Respiratory assessment that we talked about. Chest excursion, lung sounds. Are they coughing? Are they fighting the vent? Are they getting agitated? Are they maybe ready to wean? As she said, so many patients, so many hospitals now are doing these wake-up sedation vacations, some of them call it, where they cut back on the sedation, get that patient all agitated, and see if they can get them to breathe better on their own and get them off the vent. And then you have to make sure that, you know, they don't have any skin breakdown from where you've attached the endotracheal tube, and just assessing for any of the complications that we just talked about. And now your patient's ready to be weaned. So what are some of the indications? What are you going to be looking for? Taking spontaneous breaths. So you're going to be looking at that ventilator and see how many spontaneous breaths they're taking. What else? How are their blood gases? Are they improving, given the fact that they're maybe taking more spontaneous breaths? Nutritional status. And so now we've extubated your patient. What are you going to do to assess and maintain and prevent and monitor for complications immediately after extubation? What are you going to do? Yep, respiratory status. So how often do you think you might need to do that immediately following extubation? Every 5 minutes. Because that patient can have a spasm of their trachea just as a reflex from the removal of that tube. They can, if you hear stridor, you're going to do what? Call 911. No, you're going to get some help, because if that patient has stridor, that indicates that their trachea is spasming, their airway is spasming, and they may need to be reintubated. So all these things are going to be part of that assessment. Just because we get extubated them doesn't mean they're flying free. There is always that problem that can happen. So that is it for ventilators. That's what you need to know about them. What do you as the nurse need to do for that patient? What do you assess? What's the complications? Don't worry about doing the settings. The respiratory therapist is going to take care of that. You just want to check that patient's pulse ox, make sure that they're well oxygenated, make sure that physiologically they're doing great. So feeling a little bit more comfortable about vents now? Yeah?
Quick question. Might be going a little ahead of ourselves, but so in regards to our exam,
Yes?
will we be tested on just the information that you went over, or will we need some additional from the book on vents?
What I went over. And that's pretty much the rule of thumb, because, you know, even though there's a lot less extra fluffy stuff in this book than there was in Iggy, most of the stuff in the book is need to know, but there are some areas where she gets way too far into almost critical care concepts, more than what you need to know at the entry-level nursing. So what I talk about in class, what's on the PowerPoints, what's on the video, hopefully that I'll be posting, that's what you need to know.
So is it recommended that we read the book?
Oh, absolutely recommended that you read the book. Absolutely. Because that's how you're going to prepare for the class, because when I'm asking these questions, if you haven't read the book and jotted down some notes, then you're all going to be staring blankly at me and I'm going to get annoyed. But you're not. Okay, a little bit on community-based care for patients that have had respiratory issues, because they are things that you're going to encounter, either if you're the home care nurse or you're the person setting up the discharge process for your patient. So patients need to meet certain criteria in order for Medicare and other insurances to pay for their home oxygen. And the criteria is usually a pulse ox less than 88% on room air, which is why you will often see the therapist, the respiratory therapist, or the nurse, or somebody, even the PCA, walking that patient around the hallway with no oxygen and a pulse ox on their finger, because you want to get them down to 88% on room air so that Medicare will pay for their home oxygen. Usually there's another criteria if their PaO2 on their ABGs is less than 55, but that's not something that's, you're going to be constantly drawing ABGs, and when that patient goes home, you're certainly not going to be drawing ABGs on them, but you can do a portable pulse ox and get readings for that in case they need to get recertified for their home oxygen. So if you're the discharge planner, you need to make sure that all that stuff is out there in the house, ready for that patient when they get home, and that whoever's coming to pick them up, if they're not going home by ambulance, has a portable tank to bring them home. Yes?
Now, what time frame do they need to have that low pulse ox? We figure when they're discharged, they're better.
Right, but so it's usually right before discharge when they're trying to determine, when the discharge planner's making the phone calls to the VNA and the DME suppliers, durable medical equipment. Then the doctor will say, okay, the patient's been kind of unstable, we got him down to maybe 1 liter or 2 liters, but then every time we take them off the nasal cannula and they do a few activities, they desat. So we want to make sure that we can get home O2. So then they'll do an official, usually the respiratory therapist, if there's an order, then usually the respiratory therapist has to do it, and they'll go and walk the patient around and document, yes, we've got less than 88%, so we can, then we can order the home O2. Yes?
I see a lot of, when I deal with like O2 companies, they come in and do like an overnight test where they put the probe on them overnight. What are they trying to check there?
I'm not really sure. That could be for their own accreditation and billing issues to make sure that they're verifying so that it doesn't come back to, the insurance company saying, oh, well, we decided we're not going to pay you, because you don't have enough of from your end, validation and documentation. It's all about the documentation wherever you go in healthcare now. So you need to talk to your patient about, you need to make sure that you've got the visiting nurse to go out there if they're new to home O2 to make sure they're teaching them all about oxygen safety. And then the patients are going to need portable tanks. Most patients will have an oxygen concentrator that's obviously run by electricity, but they should also have a backup tank that doesn't require electricity, particularly in this area of the country where we're constantly having power outages. So they need to have a backup and not have to depend on oxygen, on electrical delivery of their oxygen. And most of the time in home care, what we had to do is we had a list that we submitted to the EMS on a continual basis of people that that had home O2 that might need to be evacuated in cases of emergency, and what type of equipment that they needed. Because once they get out into the community, they got to have the backup. They got to, because remember we talked about all that liability stuff. If you're the discharge planner, you've got to make sure they've got what they need out in the home. This book it talks a little bit about pulmonary arterial hypertension. So what is that? What's the definition of it? What's the pulmonary artery? What do you remember from anatomy?
Goes to the lung, brings blood to the lung.
Brings blood to the lungs. So if you have a high pulmonary artery pressure, what do you think can happen? If a high level of blood, high pressure of blood go into the lungs, what can happen?
It meets resistance.
It meets resistance.
Backs up into the right ventricle.
It can back up,
That to get bigger.
and it can cause damage to the lung as well. So so you need to the pulmonary artery pressure has to be measured with the pulmonary artery catheter, which we're going to talk about when we get into cardiac. You may have heard it referred to as a Swan-Ganz catheter, and it's threaded into the right atrium, and then it's wedged into the pulmonary artery, and it tells you what the pressure is in the pulmonary artery. Again, you don't need to know the values, just to know that patients can have what's called idiopathic pulmonary artery hypertension, which is we don't know what causes it, and then secondary hypertension based on other issues, cardiac issues usually, or pulmonary disease that raises the amount of pressure of the blood going into through the pulmonary artery. Patients are going to be short of breath. They're going to get chest pain, syncope, and primarily the diagnosis is going to be that pulmonary artery catheter measuring the pressure. But you'll see the history and physical is going to help, chest x-rays, pulmonary function tests, a huge cardiac and pulmonary workup to diagnose the condition. And our treatment is if it's not the idiopathic, which we don't know what the cause is, so we really can't treat an underlying cause. But if we know what the underlying cause is for that secondary PAH, then we can treat that. The focus is on oxygenation, because if there's extreme pressure of the blood going into the lungs or backing up back into the heart, they're not getting good oxygenation. And patients with severe PAH may even need a heart-lung transplant. That's all you need to know about that. What's that? That is a clot. That is a pulmonary embolus. That is a pulmonary embolus in the right and left pulmonary arteries. I would say that's probably post-mortem. Because you can see that whitish area around that black snaky thing, that's the inside of the pulmonary artery where they've kind of opened it up and flapped it over and exposed that. So that is a pulmonary embolus. So, what causes a pulmonary embolus? What is Virchow's triad? It is on page 502 in your book if you didn't find it. But who can tell me what Virchow's triad is? Triad meaning 3. So 3 things that do what? Cause that predispose patients to have clots, usually DVTs. Stasis, venous stasis. So what types of conditions would cause venous stasis? Sitting too long on a plane. So immobility. What else? What else prevents blood flow from coming back from the legs? What's that? Crossing your legs. Diabetes is more damage to them. We're going to talk about that in a bit. What's that? Vented patients, because their venous return is and the immobility. Patients who have had surgery that lasts longer than 45 minutes are at an increased risk. Now, most surgeries last a heck of a lot longer than 45 minutes. Obesity, pregnancy, CHF, the pooling of the blood in the legs, venous stasis. Okay, so anytime there's a reduction of blood flow to the heart, puts that patient at risk for developing blood clots. What's one of the other parts of the Virchow's triad? Yes. That would be a venous. That would be a stasis situation in the actual AFib. AFib, right. But what else is going to cause the development of clots? You got stasis, damage to the blood vessel. That's where some of the damage done by diabetes can come in. Because if the inside of the blood vessel is not nice and smooth like that, but it's all rough because of damage from diabetes or previous DVTs, which is why the person who's had a DVT is at a much higher risk for having another one because they've had damage. Traumas to the blood vessels, sepsis, any of those things that damage the inside wall that make it rough so that the platelets break up and they cause clots. And then what's the third part of the Virchow's triad? Hypercoagulation. So anything, any condition or situation in that patient that causes them to abnormally clot at a higher level than usual. So what kinds of conditions might cause hypercoagulability? DIC, disseminated intravascular coagulation. Talk again a lot more about that with shock. What medication is a very common cause of blood clots? Birth control pills, oral contraceptives, any kind of hormone is going to put a patient at a high risk for developing blood clots. So if they're on hormonal replacements, chemotherapy for cancers, hormone replacements for menopause. All of those things are going to put that patient at a higher risk for developing blood clots. Cancers, in and of themselves, can cause a hypercoagulation. So Virchow's triad, 3 things that are going to cause that patient and put them at a higher risk for DVT, and if they have a high risk for DVT, then they're going to be at a high risk for a pulmonary embolus, because that DVT can break off and go, you know, because we're talking respiratory, go to the lungs. And if we were talking cardiac, it could break off and go to the heart and cause an MI, or break off and go to the brain and cause a stroke. And we are going to stop here because we're going to do a case study for pulmonary embolus, and we really don't have enough time to do that.
Where does the charity come in?
Okay, let me just stop the recording here.